Children's Health. Today's meeting is taking place in a hybrid format pursuant to the House Order of June 23rd, 2022. I'd like to make a few comments for the benefit of witnesses and members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you're not speaking. For those of you on Zoom, you have the choice at the bottom of your screen of either Floor, English, or French. For those in the room, you can use the earpiece and select the desired channel. Screenshots or taking photos of your screen is not permitted. The proceedings will be made available on the House of Commons website. In accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests in advance of the meeting. I am participating remotely today because of the situation here in Prince Edward Island. I'm in one of the few buildings in Charlottetown that has electricity, and hopefully it'll be stable enough to get us through the meeting. I would now like to welcome our witnesses who are with us this afternoon. From Children's Healthcare Canada, Emily Grunwald, President and Chief Executive Officer. Representing
the Association of Pediatricians of Quebec, Dr. Marie-Claude Roy.
President.
She's a pediatrician and president.
In Pediatric Society, Dr. Mark Feldman, President. Thank you to all of our witnesses for taking the time to be with us today. Each of you has up to 5 minutes for an opening statement, followed by a period of questions and answers. I would like to invite Ms. Grunwald to begin. Welcome to the committee. You now have the floor.
Wonderful. Good morning, and thank you for inviting my participation today. My name is Emily Grunwald, and I am the President and CEO of Children's Healthcare Canada. Children's Healthcare Canada is a national association that represents Canada's 16 children's hospitals, as well as community hospitals, rehabilitation centres, home care, palliative, and respite care providers that serve children and youth. Our members span the full continuum of care, giving us a unique perspective into the health systems that serve 8 million children and youth, a population that continues to grow. Where Canada once ranked amongst the top OECD countries with respect to children's health outcomes, the 2020 UNICEF report card reveals that Canada now stands worlds apart from other rich countries when it comes to providing healthy, happy childhoods. Canada's standing has slipped to 30th of 38 countries with respect to physical health and 31st out of 38 countries with respect to mental health. Relative to our wealth, Canada punches far below its weight when it comes to children's health. In Canada today, over 30% of children and youth suffer from chronic disease. 1 in 5 experience chronic pain. Pre-pandemic, our children were amongst the least vaccinated amongst OECD countries. We also have one of the highest rates of adolescent suicide in the developed world. At the same time, in Ontario, over 28,000 children and youth are waiting to access mental health services, some as long as 2.5 years. In the wake of the COVID-19 pandemic, children's healthcare systems are facing unprecedented demands. From coast to coast, children's hospital emergency departments are experiencing historic patient volumes, approximately 30 to 50% higher than usual. Children and youth are often waiting 10 to 12 hours to be seen. Many of those who are admitted for serious health conditions are admitted without bed, which means there's no immediate capacity to care for these children. In this situation, to create space and free up beds, children's hospitals are cancelling and rescheduling essential surgical procedures, putting children at risk of missing critical developmental milestones. Mental health visits and admissions are a particular and ongoing concern. Many children's hospitals are experiencing a threefold increase in the number of patients presenting with acute eating disorders and nearly double the number of patients presenting with anxiety and depression. Between lengthy waits for mental health, surgical interventions, diagnostic assessments, and child development services, children are now waiting longer for essential services than many adults. At the same time as children's health systems are facing extraordinary demands for services, these organizations are struggling to recruit and retain a skilled workforce. Children are not tiny adults. The healthcare providers who care for Canada's smallest patients are amongst the most highly specialized. This remains one of the most pressing, complex challenges in our health systems today, and I recognize has already been a focus of study of this committee. In 2020, in response to the crisis our children are facing, Children's Healthcare Canada partnered with the Pediatric Chairs of Canada, UNICEF, and CIHR to launch a pan-Canadian initiative called Inspiring Healthy Futures to measurably improve the health and well-being of children, youth, and families. A broad cross-sector consultation engaging 1,500 individuals and organizations who identified 5 interlinked priorities to create conditions for children to thrive. The report underscores the need for children's health and well-being to be a priority for the public, for funders, and for decision makers. Canadians imagine a healthier future for their children. The time is right for the federal government to develop a pan-Canadian child and youth health strategy. This strategy must enable better beginnings by prioritizing maternal and newborn health to give families the best start possible, advance precision medicine and wellness through world-class care for sick children requiring hospitalization, and enable children living with neurodiversity, disability, and chronic disease to transition from vulnerable to thriving. A comprehensive strategy would not only address existing gaps, but also anticipate needs of the future. First and foremost, we have normalized rationing and waiting for mental health services to the detriment of kids, while we know that early intervention pays lifelong dividends. A commitment to earmarking 25% of the proposed Canada Mental Health Transfer for children would be a great place to start. A robust maternal and child youth research agenda is required to contribute to the generation of new knowledge and to leverage this evidence to inform policy, programs, and services. We need a health human resources strategy which includes a focus on the unique skills and experience required to deliver care to kids. The strategy must address current labor gaps, but also look forward to foster resilience and sustainability. An integrated cross-sector, cross-jurisdiction health data strategy is overdue in Canada. What gets measured matters. We urgently require a strategy to address delays in access to essential child development, surgical, and diagnostic services, and we must improve services to rural, remote, and Indigenous populations. Finally, access to safe and effective medications for children is paramount. An estimated 80% of medications currently prescribed to children are administered off-label, deviating from dose, administration, patient age, and often indication listed on the Health Canada approved product monograph. Colleagues, we stand at a critical juncture. We need to both address the crisis today facing children and youth and the health systems that serve them, but also plan for our future. We have the expertise, knowledge, and tools to restore our global standing in children's health. Now all we need is bold leadership and a commitment from governments to make this possible. Thank you.
Thank you, Ms. Grunwald. Suite represent.
Next, we will hear the Association des Pédiatres du Québec, Dr. Marie-Claude Roy. You have the floor. Hello. Thank you all for giving me this opportunity to be here today and to transmit our concerns. Of course, you have no doubt, as president of Quebec Pediatricians Association, I'm head of over 750 pediatricians in Quebec who have expert practices in various sectors, neonatology, intensive care, community pediatrics. We know that the issues vary a great deal from one pediatric community to another. But what unites my members is the concern about the health of our children in the current context, especially in the post-pandemic context. First of all, when we're talking about children's health, we must recognize that, of course, they're all the physical issues that we think of first, but developmental health of these children as well. A child or children are the only population whose evolution is dynamic, and we know that developmental issues are extremely important and are an integral part of child health. We can't abandon psychological health, which has been shaken in the last few years, and there's educational health, as I would call it. Academic issues were very important in the last couple of years with interruptions of schooling because of the pandemic. And these are the future parameters of the health of these children that have been shaken. What we have to understand is that many parameters of child health are improving. There's been better survival at birth. Vaccination, although it's suboptimal, continues to improve. We know that prevention programs across the country have positive effects. We have fewer severe traumas, greater impact of prevention. We have to continue to invest in that. But there are some issues that are of grave concern. 12% of children between 0 and 5 are in precarious financial situations, and that's an important factor. 20% of children, so 1 out of 5, go to kindergarten with major developmental issue, be it motor, language, or social skills. In Quebec, for example, from an early age, a program was deployed in the early years, Agir Tôt, to determine problems before it gets worse so that parents and educational environments can stimulate these children and completely change their trajectory. For school-age children, there's obesity, there's exposure to screens and technology, and that brings about a sort of addiction which has significant repercussions for the health of these future adults. We know that child health is a tributary of adult or parent health, financial and physical, but psychological as well. The pandemic increased the vulnerability of these children. We've seen more financial precarity. We've seen more domestic violence, mental health problems among parents. Unfortunately, very few resources are dedicated to psychosocial support for these children and their families. Sooner or later, we have to address that problem. Among adolescents, we're seeing the crystallization of these problems that started in childhood. Obesity has never been higher, sedentary behavior that exploded with the pandemic. But the pandemic also had an impact on their development. Adolescents were more deeply affected than others. Anxiety and depression among adolescents has increased, eating disorders, substance abuse. So that's a population that we have to take a close look at, inevitably. The concerns of my association are to put the child back at the heart of our priorities. We know that technological evolution has allowed us to have greater quality of life, but we're stuck with health problems because of technology. Everything's accelerated. Everything goes through screens and social media. That is very important for those patients. Technology has allowed us to optimize life expectancy of very sick children who in the past could not get beyond 5, 6, or 7 years old. We have patients who, yes, are saved in the first years of their life, but have no more resources after they leave hospital. We're talking about children with tracheotomies, early premature babies. Unfortunately, the caregivers of these children don't have much support to thrive. So for the future, we hope to give further tools to mothers and fathers as soon as a child is conceived in order to optimize the growth of those children and their families. We want to prevent things to limit the impact on child health, make sure they have stimulating environments such as daycares, schools, etc., and realize that our lifestyle has an impact on the health of the young generation. We have to facilitate access to care and transfer young patients who become adults and have chronic diseases. We have children who are 15 to 18 who become adults, and we have very little expertise to accompany them when they become adults, when they have a heavy diagnosis. We know, and discussing this with my counterparts in other provinces, we know the issues are similar from coast to coast to coast for the pediatric population. Structures in each province and issues vary from province to province, and we have to take that into account. Thank you very much. Thank you, Dr. Roy.
The Canadian Pediatric Society, Dr. Mark Feldman. Welcome to the committee, Dr. Feldman. You have the floor.
Bonjour, and thank you for the opportunity to speak to you today. My name is Dr. Mark Feldman. I'm a pediatrician, and I've worked at the Hospital for Sick Children in Toronto for the past 30 years. I'm speaking to you today, however, on behalf of the Canadian Pediatric Society as its 101st president. The CPS is a voluntary professional association that represents approximately 4,000 pediatricians across our country. You've just heard that there's a critical gap in timely, affordable, and equitable access to mental health care across Canada for children and youth. But what I wish to do today is to provide some additional context, the perspective of pediatricians from your provinces and offer some potential solutions. The other day, Dr. Unger spoke to this committee about the concept of resilience. Resilience is in part mediated by brain plasticity. Brain plasticity is the ability of the growing brain to adapt, heal, and develop normally if positive changes are made early. Dr. Unger emphasized that missed opportunities to treat mental health disease during childhood has devastating consequences later in life. Children with attention deficit disorder, for example, will have more typical, more normal development of their brains as demonstrated on pictures of the brains. Serial imaging studies with magnetic resonance imaging will be more normal if they receive treatment early for their ADHD. An example of what early intervention might look like, I have a patient that I think illustrates it well. So Kareem was referred to me at the age of 10 with behavior problems. His father was not involved. His mother struggled with alcoholism, and his brother was in jail. Kareem was a good kid, however, smart, kind, charming, but he struggled with impulsivity and inattention, so he struggled socially and academically. He was diagnosed with ADHD, received treatment at a critical time in his brain development, improved dramatically and rapidly. And fast forward 15 years, I had the honor of attending his university convocation along with his mother and his fiancée. He is now a loved, respected, tax-paying member of society. Was this a one-off? High-quality research has demonstrated that intervention for children and youth with ADHD, for example, can lower the risk of school failure, suicide, drug addiction, teen pregnancy, car accidents, incarceration, and improves the quality of life, improves the likelihood of higher education, and even lifespan. The implication of early intervention and cost-averted care for children and youth with mental health disease is significant. Mental health problems serious enough to disrupt functioning and development affect approximately 1.2 million children and youth in Canada that we know of, yet fewer than 20% of those receive appropriate treatment. And this gap existed long before the pandemic. And children and youth who are immigrants or refugees, are BIPOC, or live in remote communities are even less likely than their peers to receive appropriate mental health care and are more likely to use services like emergency rooms when in crisis. I recently had the privilege of meeting with the presidents of the provincial pediatric societies across Canada to identify priorities nationally and share strategies locally. And without exception, each provincial lead identified that mental health care access gap for children and youth to be a number one issue. As you know, in 1985, the Canada Health Act was created to, and I quote, protect, promote, and restore the physical and mental well-being of residents of Canada, to facilitate reasonable access to health services without financial or other barriers. In Toronto, there's a clinic in North York which offers care for children with learning, mood, and anxiety issues, and the initial assessment by a physician costs $2,000, followed by a psychoeducational assessment at the cost of $5,000. Therapy sessions, if necessary, quickly add up to another $3,000. That's a $10,000 bill. The wait time for publicly funded mental health care in different provinces to see somebody like me is anywhere between 6 months and 2.5 years. If I then refer for therapy, talk therapy, psychology services are generally not publicly funded in Canada. So on behalf of the Canadian Pediatric Society, we ask the federal government to uphold the commitment to establish a fully funded permanent Canada mental health transfer, and that 30% of federal mental health transfer payments are directed towards those under the age of 25 to ensure timely and equitable access to mental health care. And some of the ways that money can be spent is funding the development of clinical practice guidelines, educational tools, navigational resources and systems, as well as funding continuing professional development training program for practicing healthcare providers to upscale our skills and to support evidence-based mental health care for children and youth. We'd like to see that money is spent to ensure that assessments performed by psychologists and therapies delivered by psychologists or by other non-physician mental health care practitioners are similarly publicly funded, regulated, and evidence-based. And I look forward to your questions. I have all kinds of potential solutions, and I look forward to your questions. Thank you.
Thank you very much, Dr. Feldman. And we're going to go right to questions now, beginning with the Conservatives. Dr. Ellis for 6 minutes, please.
Thank you very much, Mr. Chair, and I want to thank all the witnesses for being here. A very, very important topic for all of us as Canadians, and certainly we look forward to digging a little bit deeper. Primarily, the unfortunate thing is this study has morphed a bit into something that we didn't really anticipate in the beginning. And one of the things I'd like to get out there right away is if it really becomes the will of this committee to create a child and youth strategy for Canada, certainly we're going to need more meetings and more time to actually develop such a strategy or put us on the right path to do that. So I'll leave that seed as it is. First and foremost, perhaps I'll start with Emily. You talked a bit about outcomes in your opening statement, and I'm wondering if you might. I realize it's a big topic, but comment a bit on how our outcomes for children in Canada fell from perhaps 10 out of 38 wealthy countries to 30 and 31st of 38 countries. If you could start with that, please, I'd appreciate it.
Sure, thank you. So this is in reference to the UNICEF Report Card 16, which was published in 2020. Just to summarize, Canada now ranks 30th out of 38 countries with respect to children's physical health and 31st out of 38 countries with respect to children's mental health. As recently as 2007, we were ranked 12th in a comparable ranking conducted by UNICEF. So our rankings have fallen. The scorecards are not directly comparable, but the pattern is clear and the outcomes continue to worsen for many Canadian children and youth. So just to give you an idea, with respect to mental health and happiness, almost 1 in 4 children reports low life satisfaction, which ranks us 28th. Canada, again, has one of the highest suicide rates for adolescents, 35th out of 38 countries. With respect to physical health, Canada has an infant mortality rate of 0.98 deaths per 1,000 births, which puts us in 28th place. And to a comment by Dr. Feldman, I believe it was earlier, 1 in 3 children is overweight or obese in this country. So in almost every ranking with respect to physical and mental health, we are in the bottom third, if not the bottom quarter of rankings of comparable international countries. To a comment I made earlier, compared to our relative wealth as a nation, we would expect our outcomes to be significantly higher, especially when we look at the investments that we are making and the outcomes that are tracking towards those investments. So it is an opportunity, I think, where not only would extra investments make a difference, but a broader strategy that incorporates both health and well-being metrics is overdue for this country if we're going to measurably improve the health and well-being of children and youth.
Thank you very much for that. I appreciate it. Dr. Feldman, if I may, you made a few comments with respect to access to mental health as being the #1 issue. A couple of questions around that, if you would, please, sir. Understanding 2 parts to the question. Do we have enough pediatricians? How do we, if yes, great. If not, how do we entice them to become pediatricians through training? Are they paid enough, et cetera? And secondly, you talked, sir, a bit about psychologists and understanding, certainly in my practice lifetime, it appears that we don't have enough psychologists either, certainly not in the adult world or the pediatric world, and you did mention a bit about funding. So I wonder if you could comment on the availability of those specialists and how you think that might be solved.
Thanks. That's a great question. I should say that the #1 issue identified was mental health issues during that recent meeting. The #2 issues with human resources, period. Shortage of family doctors and pediatricians. And that's part of the access issue. So there's a number of potential solutions. One of them is that the Youth Hub model of delivery of mental health care might be further expanded. And that's, I happen to work in a rural area once a month in which there's a nurse practitioner and several workers who are trained in the delivery of psychological therapy, cognitive behavioral therapy. So perhaps a more effective use of physicians' time with partnering with colleagues in like a youth hub model can be explored and grown. The second thing is that the physicians who are out there should be perhaps better trained to manage mental health issues. And I think funding for continuing professional development opportunities might be a way that it could address the shortage of mental health care. So in Manitoba, for example, CanReach program is funded, is subsidized. And if there's programs like that that can be subsidized, or then we can get better, more efficient, refer less, and less ends up in the emergency department. In terms of addressing human resource issues, we need to train more physicians, I think. Their demographic, there's a lot of us retiring. I hope to go for another 5 years or so, but I would like to see the young folks get out there, perhaps with a little bit of an additional curriculum with regard to mental health training. So for example, the family medicine program is expected to change from a 2-year program to a 3-year program over the next 5 to 10 years, recognizing increasing complexity. If mental health care competencies can be a greater part of their curriculum, that's another way to deal with that. Additional training for pediatrics. Last 10 years at Sick Kids, we've had a program called Community Pediatrics, which is an additional year of training to teach the skills needed out in community pediatrics. The curriculum is heavy on mental health care delivery. So there's a number of different ways of doing it, but we need to train some more generalists. We need to train them better. We need to use them more effectively, perhaps in a youth hub model. And I think until we address the human resource issue and the efficiency of the system, we're going to be struggling.
Thank you, Dr. Feldman. And Dr. Ellis, next we're going to go to Dr. Pawlowski, please, for 6 minutes.
Thank you. Now, certainly I understand and can appreciate under COVID, there's been worsening rates of mental health problems and suicides. But I did want to comment on, because is it Dr. Grunwald commented on Canada's high infant mortality rate. Now, my understanding is we're 31st of 37 OECD countries in terms of infant mortality. However, part of that difference is attributed to the fact that most European countries don't include newborns weighing less than 500 grams, which certainly have a much higher mortality rate. They don't count those as live births. So that is part of the explanation as to why we have a higher than normal infant mortality rate. Is that true?
I don't have that data at my fingertips, and just as a correction, I'm not a physician, sir.
Okay. The second thing I wanted to talk about, we have a lot of doom and gloom on children's health, but as somebody who's worked 35 years as an acute care doctor, and certainly a big part of that has been looking after children, it would seem to me, if you look at infectious disease, which is a big cause of physical morbidity and mortality in children, that has really, in my experience in 35 years from when I started practicing, has appreciably decreased. Now we have vaccinations for Haemophilus influenza, meningococcus, pneumococcus, and certainly now, when I started practice, meningitis wasn't uncommon, bacterial meningitis. Now you practically never see bacterial meningitis. Epiglottitis, caused usually by H. influenza. You hardly ever see it anymore. I think a lot less pneumonias. Even a colleague of mine who I went to medical school with, who does family practice, he was saying he figures he sees a lot less otitis media, again, probably a result of those vaccinations. Now, having said that, we're seeing some troubling numbers in terms of vaccination in Canada. Apparently, only 76% of children are vaccinated with DPT polio. And under COVID, apparently in parts of the country, Manitoba, Alberta, we're seeing 20% decrease in vaccination. I wonder if you could comment, I see Dr. Roy shaking her head there, if you could comment on how important vaccines have been in terms of improving children's health and what is happening in terms of decreased vaccination rates in Canada.
Oui, en effet.
Indeed. I think in the past few years, and I talked about the impact of social media, disinformation, adolescent anxiety, but I think that nonetheless, when it comes to vaccination, unfortunately, there's a big echo chamber in terms of the sources of information for parents. We have parents now who want to know, who want to control, and that's linked to collective anxiety, I'd say. And when they go to get different sources of information that may be not too reliable, I think there's a problem there. They want to control the health of their children, but unfortunately there's misinformation or disinformation. That brings us back to prevention. We try to act a great deal when problems occur, but unfortunately the poor cousin of all this, even though there's eloquent proof that prevention has a major impact. I have a colleague here in Sherbrooke who works on sensitization to vaccines, and the proof of these studies have been disseminated internationally, but in the first hours of life of a child, he talks to parents to de-dramatize the situation, answer their questions, and deconstruct myths about vaccination. And when parents are not threatened, when you have a doctor in front of you saying you have to vaccinate your child, people are on the defensive. But if during the first hours of parenthood you welcome their concerns, there's a major impact on the vaccination rate in the following months. So we have to avoid being paternalistic. Parents need to control things. They have to understand why things are done. And by listening to their questions, we can deconstruct this. You're right to point out that despite the problems we've raised, lifestyle, the ways that infection is looked after, there's been incredible progress in the past 2 decades, but the threat is disinformation, and we have to be open to parental concerns.
If there's any time left on the same issue.
You still have a little over a minute, Dr. Pawlowski.
I wondered if Dr. Feldman wanted to reply to that, and I'm kind of sensing he may be pediatric psychiatrist.
No, I'm a general pediatrician, and I saw Haemophilus influenza type B wiped out of ICUs, so I completely agree. Vaccinations has been a huge success in my lifetime. But we're seeing polio come back now. So the disinformation that Dr. Watt spoke about is huge. I mean, that's got to be a huge priority for us, is managing misinformation, disinformation. So I've seen acute care issues, infectious disease issues improve, but I've seen mental health deteriorate.
Okay. Thank you, Dr. Feldman and Dr. Pawlowski. Bienvenue à Monsieur.
Now, I'd like to welcome Mr. Villemure to the committee. You have the floor for the next 6 minutes, sir. Thank you, Mr. Chairman. I wish to thank all the witnesses for their presence here today. My questions will be mostly for Dr. Roy. We're talking about funding healthcare and organizing it. In your opinion, what's your position on the provinces and territories' unanimous request for increases in federal transfers for health from 25% to 35% of total costs? Excellent question. At the outset, I think the Canada Health Act stated originally that it was supposed to be 50%. Now we're 22%. If we look at it from the angle of children, even if I have colleagues in adult health care who have the same concerns as I do, if you consider that 40% of the health budget in Quebec is dedicated to health care, partly because of an aging population, that doesn't leave much wiggle room. or freedom to invest on other issues that have a major impact on child health. Yes, we're talking about health transfers, but we have to remember this is provincial jurisdiction. That's never been called into question. The provinces can invest on other parameters like education. I talked about that a little earlier. But the state of our school system from coast to coast to coast is such that it's deplorable, really. Education, literacy, numeracy, avoiding dropouts, that has a major impact on health when they become adults. So these transfers giving full latitude to provinces that know the structure better than anyone else. The problems are the same from province to province. In the pediatric population, the mental health issues exist everywhere, but we must note that the structures in place are not the same from province to province. I hear myself in an echo, I'm sorry. The deficiencies are not in the same place necessarily. To my mind, it's quite clear that these transfers have to be improved to give us the freedom to act on health parameters that are proper to each province. And education and environment, too. That'll have a major impact on child health. So that money is well invested. Thank you very much. So in your opinion, if I interpret you correctly, the federal government is not in a better situation than provinces to invest the money. Well, what you have to realize is the provinces know the unique characteristics of their province. New Brunswick, Ontario, and Quebec don't have the same problems, even though they're similar. They're often in a better position to determine priorities, if only because historically these are things of provincial jurisdiction. So restructuring, investing in the right things in the right way, as I was talking about earlier, Agir Tôt, a program in Quebec with this early stimulation and diagnosis, that may not be a deficiency in other provinces. We've invested on that. Maybe we need to invest more on adolescent mental health care because right now it's an abyss in that for that population. We're very worried. The suicide rate, depression rate, dropout rate, those variables lead us to believe that, yes, the provinces are in a better position. It's not a matter of bad management. I think I'm giving you a simple example. Passports. It's not because it's a federal jurisdiction matter that it went badly. There are other parameters that meant it was difficult to act on that. Same is true for restructuring healthcare. It's difficult for a multitude of reasons, because of the aging population, because of the labor shortage, because of the older structures and infrastructure. It's not just a question of bad management. It's socio-demographics and parameters that mean that, yes, we have to reorganize our healthcare system, but putting conditions on these investments are a bad idea. It puts obstacles between children and healthcare. So you don't agree with federal conditions when it gives its healthcare transfers. I think the federal government's concerns will be the same as those of the provinces. Putting tight parameters or restrictions, I think, would infringe on the fluidity of the organization of services and would be one more obstacle between resources and the child. And my concern is that the child should benefit from the right resource at the right time, be that child in Ontario, BC, or New Brunswick. You talked about literacy a little earlier. Could you elaborate on that a little bit, please? Well, we saw recent studies, a U.S. study, I think, but I think we can be inspired by that, given our problems here. We went 20 years back. In the last 20 years, ability in reading and writing among young children, the pandemic brought us backwards 20 years. So we have an educational trajectory that's positive. That means there's a lot of children getting their diploma, but what's important is reading at the early elementary years. That's why I was talking about psychological, physical, and educational health, as I call it, because we have children who are in 3rd or 4th grade and who have only known school during the pandemic. They've seen interruptions frequently. That's one example, I think, of the unique characteristics of one province or another. I was very concerned to see that in Ontario, there are children who still have the choice of not going to school physically after COVID. To our mind, attending school without compromise is very important because it's those abilities, literacy, numeracy, will mean that the trajectory of these children will be better. As soon as school started in spring 2020, it wasn't a choice. Unless there was a major problem, children had to go to school because those are important health parameters. Attendance in school is very important for academic skills, but also the social safety net that the school represents. It's important for children to flourish, not always possible at home. Thank you, Dr. Ra. Thank you, Mr. Villemure.
Please, for 6 minutes.
Well, thank you to all the witnesses for being here. We're only in our second, really, or third meeting, really, on this important study, and I already detect a theme that's coming, which is the importance of early identification, intervention, and treatment for children. We had speech pathologists and audiologists who were here last meeting who talked about that crucial period of 0 to 4 when language and communication skills are being developed. Dr. Feldman mentioned the concept of brain plasticity, and Ms. Grunwald, I want to put my first question to you. You brought up as one of your 3 suggestions, better beginnings, maternal and newborn health. Can you expand a little bit on what you would like to see as some of the elements of a maternal and newborn health strategy?
Absolutely. So to your point about those early days, weeks, months of a child's life, we know how critical maternal health is pre-pregnancy as well as their health and well-being throughout pregnancy and in those early days, months, weeks after birth. So that critical time period where we know that early intervention matters in terms of the mental health of the family, the mother, the father, others who might be part of that family, as well as the critical care that is delivered within the hospital institutions. We're seeing across this country right now increased pressures and demands in terms of the neonatal intensive care units. Unlike anything that we've ever seen before, our hospitals are now preparing different strategies to cope with that demand and to get a sense of, from a health human resource perspective, how are we training those pediatricians, those specialists, the nurses, et cetera, who are caring for children. So we need to think about the full continuum, I guess is what I'm trying to say, of the child's life, which begins preconception. We need to think about the research strategies. What are the gaps in our knowledge? We need to think about the data strategies in terms of what we understand about the health and well-being of those children at that age, and set clear targets and parameters for what that ought to look like, and looking at international comparisons as well.
Thank you. Dr. Feldman, just turning to you. Are kids in Canada, from the age of, say, birth to 5, are they getting the kind of access to therapy and treatment that they need, that could result in the kind of great stories that you relayed to us about that young man who graduated?
Yeah, unfortunately, no. The simple answer is no, that they're not getting the access. We think that it's about 20% of the people are getting access to care that they need. And so this is a grave problem right now. There's a huge gap in the delivery. One of the things, go ahead.
You maybe give us some of the key areas that they're not getting. Like, I guess this would be a relatively comprehensive problem, but where do you see the most acute needs in those gaps?
So there's a number of things. Assessments for kids with learning problems, psychoeducational assessments cost about $4,000 to $5,000. They're done privately, so most people can't afford them. And now there was a right to read inquiry in Ontario. Those psychological assessments have now been identified as a barrier to learning to read, because often an individual education plan in school is not enacted until they have that assessment, which may be on a 2-year wait list through a publicly funded assessment in a school. So assessments is one. 2 is for learning and educational issues that Dr. Waugh spoke so articulately about. The second thing is therapy. So kids with anxiety or depression, first-line therapy is a type of talk therapy called cognitive behavioral therapy. Cognitive behavioral therapy is an evidence-based, proven, effective strategy. Psychological services that deliver CBT, again, cost big money, and it's private. They're not available in publicly funded. And so often, kids are put on medication, which is second-line therapy, first for their anxiety or depression. And then kids with, sorry, go ahead.
I hate interrupting you, but I only have 6 minutes. I just wanted to shift.
Yes.
You brought up medication, which made me think of another question I wanted to direct to you.
Sure.
The Canadian Pediatric Society has been leading the call for child-friendly pharmacare in Canada. A few years ago, the CPS issued a statement with respect to the NDP's Canada Pharmacare Act that said the following: the establishment of pediatric sensitive national pharmacare is an opportunity to correct the long-standing regulatory neglect that has led to poor availability of pediatric drugs and child-friendly formulations. We strongly support a pharmacare system that prioritizes the needs of children and youth and upholds the core principles reaffirmed in Bill C-213 of public administration, comprehensiveness, universality, portability, and accessibility. Those are the Canada Health Act principles. Could you outline the barriers that Canadian children are currently facing in accessing affordable and effective medication?
I'm going to defer to Ms. Grunwald, who has been much more involved with that. On that, very quickly, there's not a lot of pediatric-friendly formulations. A lot of what we learn and apply to children's care comes from research in adults. There's a lot of medications that are simply not on public formularies. There's a number of strategies for which a pharmacare strategy will be important.
Answer that. I want you to. I'm also going to throw another question. You mentioned that Canada is 35th of 38th in adolescent suicides. Is there any data or theories as to why that's the case, as well as the other question?
I don't know that you're going to be able to get both questions in, given that we're out of time, but we'll allow you a time for a brief response if possible, and you can supplement it in writing afterwards if you wish. So a brief response, please, Ms. Grunwald.
Sure. So with respect to the pharmacare program, I think any opportunity we have to increase access to safe and effective medications for children is a step in the right direction. We know that 1 in 6 families have struggled to fill prescriptions that have been directed for their children because of cost. In terms of the safety and efficacy of the formulations themselves, 80% are prescribed off-label, which means that it is not approved regulated dosage for a child or youth. And safety and efficacy matters. Children have very specific sizes and develop at very specific stages, and so it's not appropriate to look at an adult dosage and scale back. There's lots of challenges in terms of regulatory barriers for pharmaceutical companies to invest in the clinical trials for children. So that's an opportunity that the CPS has been leading in terms of regulatory reform for pharma.
Well done. Thank you. Mr. Lake, please, for 5 minutes.
Thank you, Mr. Chair. Dr. Pawlowski brought up disinformation, and I share his concerns. In fact, I wrote an op-ed in 2018 as a parent of a child with autism to talk about Andrew Wakefield's disinformation and the impact that it had on parents' decisions to vaccinate their kids. I'm also concerned about another form of disinformation that comes in the form of a political party when it comes time to run an election, putting out promises and then not delivering on those promises, clearly not delivering, like the promise by the Liberal Party to spend $4.5 billion on a Canada mental health transfer, and on page 75 of their platform document clearly indicating that $875 million would have been allocated by now, $875 million. And Ms. Grunwald, you mentioned, I think that your suggestion was it 25% of that Canadian mental health transfer? So unfortunately, 25% of nothing is still nothing, so it wouldn't result in a change. But if the government had delivered on that promise by now and put $875 million towards a Canada mental health transfer, your proposal would mean over $200 million delivered to benefit children, what kind of impact would that have had? What would that money have been spent on had that promise been delivered?
Absolutely. So we know in Ontario pre-pandemic, there were 28,000 children on a wait list for mental health services delivered in the community or in acute care centres. And we anticipate that number has grown over the course of the pandemic. Across Canada, that number is closer to 100,000 children on a wait list. We know the impact that early intervention can make on children's mental health, and it pays lifelong dividends in terms of their overall health and well-being. 25% reflects roughly proportionate to the number of children and youth under the age of 18 in Canada. And what we don't want to see is children left behind in any sort of funding envelope to address mental health, children being an afterthought. We really want to make sure that they are prioritized in the rollout of any programs and services to improve their access to care. So whether that is increasing the number of providers who are trained in the pipeline to provide services in the community, whether that includes space in our acute care facilities to care for the most complex acute mental illnesses amongst our children and youth, those are all opportunities immediately that require investment that those dollars would support.
Thank you. Dr. Feldman, wondering if you could weigh in if that, say, over $200 million that was promised had been delivered, $800 million for Canadians across the board, but let's say that about $200 million was spent already by now, invested into the system. Where would you allocate that money or suggest allocating that money?
Similar. I perhaps looking at advanced training programs, more doctors, more training for doctors out in practice, continuing professional development, perhaps for more publicly funded therapy, and regulated evidence-based therapies. I could spend it pretty quickly.
Just doing a quick calculation, if you calculate the $875 million that was promised to have been spent by now, about $200 million would have gone to Quebec. How would that money, do you think, best have been spent in Quebec, $200 million towards mental health?
La question est vraiment pour moi.
Is that question directed at me or Dr. Feldman? Yes, I agree fully. I advocate prevention, of course. More professionals do, as my colleagues mentioned. I think that the share for children should be far higher than 25%, because when it comes to mental health, for an adolescent to become a functioning adult, you have to deploy the tools to face those mental health issues. They have to be well developed. But if we invest more in childhood and adolescent to prevent mental health problems, the entire population will benefit. So I wouldn't just use the pro rata of the population, or such and such a proportion of children. I think it's as early childhood and certainly adolescence that we have to invest in mental health. As Dr. Feldman said, we're trying to solve a problem with medication because we don't have enough resources. We're medicalizing problems that should be accompanied at an early age. And in 10, 15, 20 years, we're probably going to recoup investments in therapy and accompaniment, especially tools of all kinds. It doesn't have to be individual long-term therapy. I think there are prevention programs. A generational approach is needed to avoid mental health problems. Thank you, Dr. Roth.
Please, for 5 minutes.
Perfect, man. Perfect time.
Thank you, Mr. Chair, and thank you to all the witnesses for coming today. I'm going to start with Madam Grunwald. In your opening remark, you talked about an initiative that was launched, Inspiring Health Futures, and you talked about 5 interlinking priorities. I noticed that you ran out of time to be able to cover all those priorities, but the one, there was a number of one. There's a number of them that stood out in my mind. Naturally, we've been talking about the mental health a lot, but can you briefly talk about the research data collection and sharing of data, and as one of the interlinking recommendations, and give us some background of why data?
So I think right now, if we look across the country, different data elements related to children's health are being collected by just different jurisdictions, and they have different levels of access for folks like researchers or for program and service providers, for policymakers. And so we're looking for more of a robust, continuous, integrated data strategy that would be accessible to all those different communities to help us make better evidence-informed, more timely decisions for children and youth. Throughout the Inspiring Healthy Futures consultation, we heard a number of calls to action. So we agreed that Canada needs to develop and implement a consistent, comprehensive data set, so regardless of where services are provided and comparable across different jurisdictions, whether it's healthcare, or health outcomes, and linked to our education data as well. We also need to ensure that the folks who are impacted by this data are included in the design of the data, and that we respect Indigenous data sovereignty. And the third element was we need to make sure that, like I said, all this data is accessible to the different stakeholders who can make use of it, so that it is supporting evidence-based decisions.
Thank you. In the closing part of your remark, you talked about the bold leadership and commitment from the government. Can you elaborate on what you meant by bold leadership, and what kind of commitment are you looking from all levels of government, specifically the federal government?
So to begin with, this is a great opportunity that we have today to discuss children's health and well-being. This opportunity hasn't existed in several decades, as far as I'm aware. And so the opportunity to think about a pan-Canadian child and youth health strategy is timely and urgent, I would argue. In terms of a bold strategy, we need to think about how we are investing in policies and programs that support children, youth, and their entire families, how we make further investments, for example, in maternal and parental leave, in children's benefits, in the access to programs and services that exist. We also need to be attentive to and respect the vision that children and youth have for their future. What we learned through the Inspiring Healthy Futures report is that they have a very clear vision, and they have some very clear ideas and some very ambitious goals about what they would like to see in terms of opportunities to support their health and well-being. So I think that is important, and bearing or inviting youth to this committee would be a great start to hear from them directly what some of those options might be. And then lastly, I would say to be accountable, we need targets, we need measures, we need instruments that will hold the federal government, the provincial government, organizations like mine to account, so that we know that we're making meaningful and measurable progress for children and youth. So whether that's the idea of an independent accountability office or a commissioner or otherwise, that sort of leadership would be welcome at this time.
Thank you. I'm going to move on to Dr. Feldman. Dr. Feldman, you were talking about CBT, and you were talking about early intervention, and that being a method of making early impact on a much shorter time frame than other prescribed methods. Can you expand on that? You run out of time trying to cover that point. So I got about a minute, and I'm going to give that to you to finish that thought.
Thank you. So services offered by psychologists for the younger children that is currently not publicly funded is really about assessment for learning, behavioral, and development issues. There's small amounts of publicly funded through schools, but the wait lists are untenable. Services for kids who are a little bit older that psychologists provide, or other health disciplines trained in the delivery of CBT, similarly are very, very difficult to access, and generally speaking are not publicly funded. So CBT is an evidence-based therapy that makes considerable difference in terms of function and quality of life for kids with anxiety and depression. And so CBT is first-line therapy, but medications like Prozac are second-line therapy, but often they're started first because we can't get a psychologist.
Thank you, Dr. Feldman. And Mr. Johari, suite Monsieur Villemur pour 2 minutes.
Mr. Villemur, 2.5 minutes. Thank you, Mr. Chairman. My question is for Dr. Roy again. During the pandemic, did the provinces and territories have the same approach when it came to child health? In fact, the pandemic was like a ton of bricks on everybody's head. We can summarize it that way. There were a lot of adjustments and adaptations needed, and I can say that, and I think this is what we have to remember from Canada's strength. We were talking about leadership, exchanges in approaches, commonality of concerns. We had the opportunity to be in contact with Ontario. We advocated children going back to school early because we knew COVID was less dangerous for them. There was a risk. It was a calculated risk, knowing that given the infinite duration of this, we're still experiencing it, impact on child health would be much higher if we limited school attendance and that social safety net, the protection, if you will, the supports, financial and food supports to reduce domestic violence. We had a lot of exchanges with Ontario. They were concerned about the fact that they didn't get the same message from the Canadian Pediatric Society. So the fears were very different. Populations didn't react the same way. Healthcare systems didn't all react the same way. But communicating with each other and getting that wealth of information was a good way. No, the approaches were not the same, but we could learn from each other at CHSLDs. We had models that inspired us when there were things that didn't go very well at home. It was BC where things were going much better. So approaches weren't the same, but it's that varied color palette that means that pooling of resources can advance the fate of different provinces. You talked about a diversity of approaches. I think that's a good argument, saying that we should be inspired by other provinces, but it's up to the provinces nonetheless to determine what action they should take. I think globally each of the provinces would be at an advantage, and so would the federal government. Making it one single recipe can't work. To give you a clear example, the pandemic, and that reflects the needs of the public, which is not the same from one region to the next in Quebec, and nor from province to province. Thank you very much.
Please, for 2.5 minutes.
Thank you, Mr. Chair. Ms. Grunwald, I asked you at the end of my last round to maybe answer why Canada is 35th out of 38th in adolescent suicide. What are the causes of that?
So I'm not a mental health practitioner, but we do know that children and youth have struggled in academic environments, and the in and out of school over the course of the pandemic has likely served to stress a particular population of children who weren't thriving in the at-home environment. There are lots of risk factors at home for some of those children as well. Otherwise, the support and lack of access to community-based services, which are either preventative or early intervention services, largely aren't available or accessible. The 2.5-year wait is a very long time to wait for a child or a youth and their family when they're suffering from mental health concerns. And I would say, in addition, to Dr. Feldman's point earlier, that opportunity to train our general practitioners, our pediatricians, some of those frontline healthcare providers to earlier identify concerns and diagnose and refer is a great place to start. But we also need to think about how we deliver access to children who are rural, remote, Indigenous, new Canadians, not English first, et cetera.
Thank you. Dr. Feldman, I'm curious, in your practice or among other pediatricians, about the extent to which you see lack of access to universal dental care manifesting in children. Is that a significant oral health issue in Canada?
Yes, I do think it's an issue. It's not my area of expertise, but certainly when I looked at the first meeting of this committee, I found the concerns raised by the Dental Association leads quite compelling, and my practice is now more specialized, though I'm a general pediatrician, in kids with mental health issues and learning issues.
Do you have any explanation for why we seem to have a burgeoning crisis in adolescent suicide in Canada? What are the causes of that?
It's a lot of this is conjecture. Because the numbers are there, but much more research needs to be done. There's been a huge rise in eating disorders during the pandemic. There has been access issues that was just spoken about, I think is going to turn out to be a really big part of that. For example, kids with ADHD are more likely to commit suicide if they're not treated. In fact, specific treatment for their ADHD, not simply depression or anxiety, reduces the impulsivity and the likelihood of suicide. I think the isolation that we've all experienced through the pandemic must have played a role. There's so many different theories, but further research into this area needs to be done. Certainly, we need to address the access issue now, but more research needs to be done and more targeted approaches.
Thank you, Dr. Feldman and Mr. Davies. Next, Ms. Goodridge, please, for 5 minutes.
Point of order, Chair.
Go ahead.
Yeah, we're not hearing Ms. Goodridge in the room.
And I'm not hearing her in my headset either. So we'll see if we can resolve the technical issue and then we'll start the clock.
Ms. Goodridge, could you check the physical mute button on your headset is not pressed?
Hello?
We can hear you now, or at least I can.
Perfect. I guess this is why we should do tech checks before we start.
Just can everyone, just a second, Ms. Goodridge, I haven't started the clock yet. Can everyone hear her in the room?
Yes, Mr. Chair.
Excellent. Okay. You have the floor for 5 minutes. Ms. Goodridge, go ahead.
Thank you, Mr. Chair, and thank you to all the witnesses for your testimony today. Something that I'd like to touch on is something that's been pretty active in the news as of late, and it's something that I know touches a lot of parents and is causing a lot of stress, and that's the shortages we're seeing in children's Tylenol, Advil, and Motrin, specifically in the infant formulations. And I was just wondering if you guys have anything to add or anything that the Government of Canada could do to try and alleviate some of these shortages and diminish the stress that so many families are seeing. And I see Ms. Roy shaking her head, so peut-être vous pouvez commencer, Madame Roy.
Perhaps you could start, Dr. Roy. Thank you. I was shaking my head because that's a major problem. It's difficult to see. We've looked at this issue when there was the shortage of baby formula for children who had a sensitivity to cow's milk, same thing for Tylenol and so on. The supply, not just drugs, but it's a problem for everything. I think quite clearly where the federal government could help us is to extend a hand to other countries, to Europe, other markets, because we're limited about what is approved here in our territory. So versatility and rapidity is important. We needed that flexibility. We saw that during the pandemic. But when it comes to medication shortages for children, we have to be able to get other options and extend a hand to other countries to at least mitigate the impact of all this. That was very difficult for many parents.
I think as a mom of a little boy who has getting his first molar, the shortages has really amplified the stress, and it's made me really curious as to why something that is so required and can prevent children from filling up your guys's ERs is so hard to come by. And so I was just wondering, perhaps Ms. Grunwald, do you have anything to add on this subject?
I think, what we have been encouraging parents to do is to lean into trusted resources, which are their pediatricians or their children's hospitals for other sources of information or other advice to manage pain. There's also a federally funded NCE program called Solutions for Kids in Pain, which offers a number of different pain management strategies that parents might find of use. But to the general problem and the role of the federal government, I have nothing to add to Dr. Roy's testimony.
Thank you for that. And then I think to go back to one of the pieces that was touched on by Dr. Feldman about the eating disorders in kids, and I think that's incredibly troubling. And how young of children are we seeing eating disorders in? And are there any causes that are being identified that perhaps we could address as a government to make sure that we are taking care of these children?
So unfortunately, young kids, prepubertal kids, we're seeing eating disorders in. The cause of it is unknown. There's conjecture again. In part, I'm speaking with some adolescent medicine colleagues and asking them the very same question. One of the theories is that during a period of time in this pandemic with no sense of control, it's the one thing that they control. Other theories include online learning and dissatisfaction with their image, social media. There's a number of theories, but we don't exactly know 100% for sure.
No, thank you for that information. And so this is clearly a space where the mental health is driving some of this, and it has long-term impacts. This can impact fertility later on in life. It can impact all over health. And I was just wondering if you had anything to tell parents that might be listening as to what they could do to help prevent or help kids that are struggling with eating disorders.
Maybe I'll defer that one to Dr. Waugh. If you see a lot of kids with eating disorders, it's not a part of my practice, but in general, we know that being very positive, not telling kids obviously that they're worried about their appearance, talking about healthy lifestyles, not appearance. These are some very general recommendations. But largely why some kids are affected by anorexia nervosa and others aren't is still a little bit of unknown.
Thank you very much, Dr. Feldman. And Ms. Goodrich, next, Dr. Hanley, please, for 5 minutes.
Thank you. Thank you to all three of you for the testimony today. I'm thinking, when we're thinking of recommendations and outcomes from this study, and I think part of the context for the child health study was the pandemic and the effect of the pandemic on children's health. And I think there are various questions around what is the pandemic revealed or laid bare in trends that were already happening, and perhaps exaggerated, and then what are the direct effects of the pandemic, and then if you had your bag of $4.5 billion, what is going to heal as we heal as a society, and we can perhaps leave to heal as more of the maybe transient stress affected results of the pandemic, and where do we really need to focus on targeted interventions? I know you've both, Dr. Waugh and Dr. Feldman, talked about that to some degree, but I'm thinking of where are we? I think this amount of funding, we need to be very efficient with how we use it because it will disappear, and I think especially if not well used. And I'm thinking of where perhaps each of you could comment. Peut-être Dr. Waugh d'abord, and
maybe Dr. Waugh first.
You really put that money and get the best bang for your buck.
J'aime beaucoup.
I do like the way you presented this. The pandemic exacerbated something that already existed. If we get back to adolescence, for instance, we see that. There are many hypotheses out there, but of course, an adolescent develops because he or she can leave the family, consolidate the family values, goes toward other people, goes to the outside world. Parents become secondary. Friends become more important. They forge their personality. That's exactly what the pandemic prevented them from doing and had them fold into themselves and be completely opened all the time to images of perfection on social media. We have to consolidate what makes them solid. Consolidate self-actualization and self-esteem. That starts with support in mental health. But what makes an adolescent develop? Well, they have success in school. They get tutoring. They get validation of their academic accomplishments, sports accomplishments, positive interaction, positive models from coaches or other adults. So investing a lot on all the safety nets around the children because we name them. The family is not always solid enough to consolidate those children. So yes, we have to deploy that in healthcare specifically, but we have to give the provinces latitude to invest in other areas that have an impact on child health, education, sports, supports of every kind, and of course, prevention programs to help them evolve the right way and develop. So we have to remove those silos. It can't be just healthcare. All the parameters around a child are important so that they can consolidate. I think that's one of the solutions that we must not set aside.
Feldman, perhaps you can add.
Thank you. So I kind of think of it as both quality and quantity of healthcare delivery. And from quality, break it down into efficiency and effectiveness. So how are we more effective? We need to make sure that therapies are evidence-based. We shouldn't be giving any money to unproven therapies. So effectiveness is through evidence-based practice. Through efficiency, there's a few strategies. So one is to have perhaps the mental health care team model in which only one of them perhaps is a physician or a pediatrician or a psychiatrist. And there's a number of perhaps more cost-effective solutions and team members that can provide care. In Toronto, there's something called the Navigation Project, which helps more efficient navigation of referrals, getting the people to the right place at the right time to navigate wait lists. So efficiency through navigation, efficiency through involving our non-physician colleagues, effectiveness by demanding that they be evidence-based practices. And in terms of quantity, we need more healthcare providers.
Thank you, Dr. Feldman and Dr. Hanley. And next, Mr. Lake, please, for 5 minutes.
Thank you. Ms. Grunwald, I was really struck hearing, and we've talked a lot about it, but those numbers from the 2020 UNICEF report are very problematic, troubling. 30 out of 38 on physical health, 31 out of 38 countries on mental health. What is the connection between mental health and physical health? Maybe speak to that, because I think those numbers, it's not coincidence necessarily that we're around the same ranking in both. When we think about mental health, and I'll go to the two doctors after this, but on the same question, as mental health deteriorates, what's the impact on physical health for kids?
That's probably a great question for your two pediatricians, but my observation would be that a piecemeal approach to addressing children's health and well-being, physical health and mental health, has not served us well to date, and I think is not what is required to get us or to measurably improve children's health. So we really need to think more systemically. And what we heard through the Inspiring Healthy Futures report was there are 5 interlinked areas that require simultaneous investment and consideration. So that's around children's physical and mental health. It's around the schools and communities in which children live. It's around a robust health research agenda. It's around strong policies to support children's physical, mental, and health and well-being, social development. And it also involves that idea about empowering youth. And so I think looking forward, piecemeal investments, where do we start? We really need to think about this more systemically. This isn't throw money at one particular problem and we're going to solve children's health. But to your point about mental health impacting physical health, I'll defer to the two physicians on the line.
You first, because you were the one that raised the statistics.
No problem.
Dr. Feldman?
Thank you. So it's a great question. Kids with depression, anxiety, learning, and attention issues are more at risk for drug addiction, alcoholism, and that's going to affect your health. Kids with ADHD are 2 to 3 times more likely to be obese because of impulse eating. That's going to affect their health. And kids with eating disorders have consequences from their food restriction. Kids with mental health disease in general make poor nutritional choices, lifestyle choices. And then there's some, not to go into too much detail, there's some conditions that lead to both health and mental health issues. There's kids with medical complexity that have mental health issues as a result of their medical issues. And so they are intertwined and additive to each other.
I would add that mental health has an effect on physical health, no doubt, but physical health has an impact on mental health. And parallel to that, there's the parental mental health that has an impact on child mental health. If we're talking about psychological health, of course, our adolescents who are not doing well mentally spend more time in front of a screen, have more obesity, and so on. All those problems will lead to distress among parents. Parents who are exhausted will have far less proactive time to move and to have healthy habits with their children and healthy food habits. All this is interrelated. I think we mustn't underestimate the chronically ill patients. We're talking about mental health having an impact on physical health, but our chronically health patients who are in distress, who don't have a normal adolescence, there's a lot of psychological distress associated with that, so there's a link there too. We mustn't forget the social aspect. Children who have a far less caring family environment and attachment difficulties, that will have an automatic impact on their growth, and mental and otherwise. So we're talking about brain plasticity earlier, and that's why we mustn't underestimate the psychological health of parents. That is important from the earliest weeks of life on physical and developmental health, but also mental health.
Next, Mr. Van Koverden, please, for 5 minutes.
Thank you very much, Mr. Chair, and thanks so much to all of the witnesses today for your extraordinary testimony. I have 2 main questions. They're both a little bit vague. I've been, as we've been talking, poring over data tables and things like that, and I guess I've been a bit distracted by the numbers. And I'm curious about folks and their opinions on the sort of dichotomy between the fact that Canada tends to rank fairly high on healthcare expenditures and quite low on good outcomes. It strikes me that either our challenge is greater or the delivery is flawed or there's other factors at play. And I tend to want to resist the temptation to recommend that we throw more money at the problem. If it's not currently being spent as efficiently as other countries, then I want to investigate how we could be doing more and better with the money that's currently being spent before we react with more healthcare transfers to provinces. I really appreciate the intervention from Madame Roy with respect to sort of the upstream challenge of healthcare, primarily from a mental health perspective, but a physical one as well, in sort of preventative medicine and trying to provide better conditions rather than only just mental health services, and certainly take your comments very, very, very well, Dr. Feldman, with the need to provide more remedial services, but at the same time ensuring that we're building resilience and ensuring that kids have access to all of the things that keep them resilient, happy, and healthy, from good food, good living conditions, access to sports and the arts, really good living and working education environments. I think that's really, really key. So if we could, just a brief comment from each witness perhaps on the necessity to focus in on some key areas with respect to efficiency in spending and areas that you believe we could be more efficient in that delivery, and where that upstream challenge with respect to how maybe Canada differs. I think I'm less concerned with the rank and more concerned with just outcomes. It's obvious that we need to improve outcomes for Canadians. So perhaps I just start with you, Dr. Waugh, since you're nodding. Merci.
There are many questions. I'd say that I agree with you that it's not really the rank or number that bothers me. When you look at this more closely, we talked about what's considered preemie or a stillbirth. So we have to get away from the figures themselves and look at the outcomes, see what we want for our children and on what we can have a real impact, what means we still have deficiencies and how we can address those deficiencies. I think that unfortunately, and this is true with child protective services and mental health, we're in a network that was always used to acting when problems are already well crystallized, when it's too late, in other words. So I think we have to put the child back at the heart of our priorities and bank on prevention. It's easy to say we'll have prevention of anxiety in school, but I think it has to be societal. I'm thinking of children who don't eat with their parents who don't eat with their children morning, noon, or night. The good basic family values that mean that a child will develop properly. That's prevention too. Inform the public to eat properly, sit down to eat together, have some kind of life hygiene. That may seem simple, but that's important. We're talking about children with ADHD. It goes better when there's structure and routine, when there's a healthy lifestyle, when the child spends time outside and moves. There's less medication needed there. It's true for ADHD and other developmental problems. Prevention, too, when it comes to sensitizing the public. Children get cell phones at 10. They use them very young, and that's become a societal standard. A child's entitled to a cell phone because the parent's anxious. But that child is then exposed to cyber predators, to images of perfection all the time. There's an addiction to it. It becomes life. Life has become virtual and accelerated. So prevention has to be done in a much broader way. And it is on those parameters that we can have an impact. So yes, we have to act on problems when they occur, but we have to prevent them too. And look at the wider picture. I'm sorry, there's no more time for other witnesses. Now we have to go on to Mr. Villemur for 2.5 minutes. Mr. Villemur. Mr. Chairman, I'd like to continue with my questions for Dr. Roy. I would like to give you the greeting from Jean-Louis Garon, who couldn't be here. When it comes to the pediatricians in Quebec, what are the major issues in Quebec when it comes to delivering healthcare to children? Healthcare delivery issues that are of great concern, well, we start from early life. There are more premature children and chronic problems, encephalopathy, and so on. Those children are saved and sent home, but the parents have no support. So the issue of caregivers is very important in child health care. When you're talking about school-age children and adolescents, we're talking about psychological health, social and affective health. That's major. As you go towards adulthood, the transfer of our chronically ill patients that didn't used to survive to adulthood, well, now they do, but there's very few resources. We follow them to 18 or 21, but then we have difficulty letting them go because there are no resources for them. And accepting their chronic healthcare problems is difficult in adolescence, so those should be the priorities. Acute care access is an issue, but I don't think that's exactly the biggest concern. It's a concern among others, but there are more specific pediatric concerns. In your opinion, is the federal government investing enough money in promoting mental health for children? Well, I think the concern is there. This committee today confirms that. From one province to another, the problems are the same. The fact that we're looking at this discussion today gives me hope that there will be a lot of investment, and this is necessary because we have no choice. We can no longer set aside those problems. You talked about literacy earlier. One of the effects of the pandemic on children was their social development. Yes, that's been true from the start. Right now, we have hindsight of about 2 years. Among very young children, we saw this. There are children who had difficulty with social relationships. They would draw pictures of children with no mouth because they didn't know what a smile looked like. So we know we have to catch up because early childhood was a priority. At school age, I think it's the same throughout the country. We had to lower our objectives. We have to see this as an adaptation to the standard development of children. We don't have to look at specific grades. There is some problems. There will be dropout rates. Thank you, Dr. Roy. Mr. Villemure.
Davies, please, for 2.5 minutes.
Thank you. Ms. Grunwald, sorry if you've covered this, but I want to be clear. Do you know what portion of overall healthcare spending is currently allocated to children's mental health services in Canada?
No, we do not.
Okay, thanks. Dr. Feldman, in March of this year, CPS President Dr. Ruth Grimes wrote a letter to the federal government that said the following: on behalf of the Canadian Pediatric Society, Canada's National Association of Pediatric Health Experts, I'm writing to ask for immediate action on the federal government's long-standing commitments to support healthy eating initiatives, namely finalizing front-of-package nutrition labeling regulations and restricting the marketing of food high in sugar, saturated fats, and sodium to children. Can you outline why the CPS supports these initiatives?
Very simply, we want to promote healthy eating.
Dr. Roy, to you, both the Canadian Pediatric Society says that they would like 30% of federal transfer payments under the Canada Mental Health Transfer to be dedicated to timely and equitable access to mental health care for children and youth under the age of 25. And Children's Healthcare Canada, both appearing today, is requesting that 25% of the federal health transfer be earmarked for children. Would you support that, Dr. Roy, that a certain percentage of the federal mental health transfer to provinces be conditioned on it being spent on children?
Je pense clairement qu'il faut.
We have to make children a priority in one way or another. I think there has to be some freedom for the provinces, clearly. There are certainly provinces for which investments should be improved more than 30% dedicated to children. Perhaps there are provinces that already made them a priority. So, yes, we have to aim for that percentage. Should it come from the federal government? Should the federal government have conditions? I don't think so. Even though the problems are the same coast to coast, the measures in place vary. There may be provinces that decide to invest more, and that's a good thing. Once again, the rules, a minimum standard could be in place, but the rest should be left to the provinces. Thank you, Dr. Roy.
Next, Mr. Barrett, please, for 5 minutes.
Well, thanks to the witnesses for joining us today. I'll throw this question out and see who wants to answer first. But I'd like to talk about the backlog for pediatric cancer screening and treatment and care appointments, and see what you'd suggest as a remedy for that. A remedy to the backlog. We can start with you, Dr. Feldman.
You know what, I would probably reflect back on the first meeting that you had with regard to some of the suggestions made with regard to cancer care. The pandemic left a big backlog for surgeries and treatments. And I think there was a number of recommendations made in the first meeting about that. Certainly not my area of clinical expertise, but I have not only know of patients that have waited for cancer care, but I have colleagues who waited, 6 months to get their breast cancer surgery. So it's a big issue and it needs to be addressed, but not my area of expertise.
Okay, so I guess the areas that I would query you if they would be helpful, and that would be the places like the scaling of virtual care and increasing the number of practitioners in the field, medical practitioners, by making sure that we're licensing and speeding our training for internationally trained doctors. Would some of these areas be, or some of these solutions, do you think be immediately helpful to address this problem?
So in terms of licensing internationally trained physicians, I've been actively involved in supporting that, but with a great degree of caution. So there's a number of international medical graduates who do training at the Hospital for Sick Children, additional training. And over the 2 to 3 years of their subspecialty training, we get to know how good their training was before that and what sort of individuals they are. And then we're in a position that we can advocate on their behalf to get licensing through a process called academic licensure here in Ontario. So I've been very involved in that. I think it's an amazing potential resource to address some access gaps, but cautiously, because there are places in the world that don't have the same sort of training we do.
Dr. Roy, did you have something you wanted to add, or just your concurrence with Dr. Feldman?
Je suis en parfaite.
I agree entirely with Dr. Feldman. We must not deprive ourselves of these resources, but we have to be cautious because we have standards to meet and we have difficulty meeting the demand. Why? Because we're expecting perfection right now. That's what guides us as doctors. We want the best for our patients, so we have to maintain practice standards, of course.
And with respect to virtual care, do you see that as an emerging opportunity, one that was scaled up during COVID, and perhaps one that can be expanded on, for alleviating some of the swelling that we have in our primary care offices, as well as in emergency rooms for non-emergent situations?
Maybe I'll start with that one. So yeah, there's a real potential for value added with regard to what we've gained in terms of technology advancements, but again, cautiously. So for example, if I see a patient who's been referred to me with suspected autism and it's a mild form, I can't tell on Zoom. And I can tell within a few minutes of seeing them in person. So there's limitations to what we can provide with distance care, but it is a great additional tool for certain clinical scenarios.
And anything to add, Dr. Roy?
Oui, en fait,
Yes, there are clienteles that are well targeted for that technology for follow-up, but for the adolescent clientele, we were talking about the problem of screens. Sometimes they're more open to them because they're used to interacting virtually. So I've had great success with virtual care, great accessibility for isolated families that don't have access to our service. There may be poor families where it's easier to call or be on see us virtually than to travel. So that's something that must remain but shouldn't be overexploited because human contact is very important. Thank you, Dr. Roy.
Ms. Sidhu, please, for 5 minutes.
Thank you, Chair. Thank you, all the witnesses joining us today. We heard from you, Dr. Roy, depression, anxiety, obesity, some medical condition also lead to the bad health. And I want to bring your attention to the celiac disease. Can develop at any time. After wheat or other gluten food are introduced into the diet, many kids are diagnosed with when they are between 6 months and 2 years old. Celiac disease is treated by not eating gluten, but this can be hard because gluten is in many foods. Same thing, the diabetes type 1. So the kids, how can teachers and school play a role to assist children with that kind of chronic conditions?
You're highlighting the importance of teachers in healthcare. You're talking about 2 frequent problems, but there are many others. There's a great deal of pressure on teachers right now. They have to be familiar with behavioral issues and now celiac disease, diabetes, what have you. So one of the secrets, and there are many pilot projects in Quebec about this, but it's the partnership between the healthcare system and the school system for behavioral difficulties and developmental difficulties, but also healthcare. There are often nurses in schools, but fewer and fewer because there's a shortage of nurses. But I think that frequent contact, having the healthcare system accompany the teaching system is a key to success. The family has to have good tools, but the schools have to have them as well.
To follow up that, we also heard a bit about the impact that the increased use of social media and screen time is having an impact on children's health as well. Do you have any thoughts on how we can best promote health and development for our children as an increasingly digital world?
I think that quite clearly the threat, to my view, is the fact that we're making all this normal, banal. At a daily basis, I see parents where I have to call into question that 12 hours a day on a screen. Everybody looks at me as if I was crazy. We have to make parents more sensitive to their role as parents. Inform society it's not normal for a child to walk around with a screen 12 or 18 hours a day. The same way we have prevention through regarding smoking or physical activity, that's an opportunity as well as a threat to this generation. It's a threat to family life and development of children.
Dr. Grunwald, I heard very positive feedback from the virtual care because some older folks and then due to lack of time, virtual care is a good tool. So what do you think, do you see any gap, or do you think virtual care is good for the Canadians?
Earlier was there's been some very positive early outcomes that we've observed in terms of accessibility to healthcare services, especially for families of children with medical complex conditions who are making frequent visits. It saves time, it saves dollars, it supports them in their family environment. So I think from a health systems perspective, there's lots to learn, there's lots to watch, but there's been lots of very early indications of success, and we've seen lots of innovative programs and services pop up, including the virtual emergency departments and other virtual clinics to serve specific patient populations. So I think it is a promising step in the right direction.
Thank you. And my question to Dr. Feldman, we did a human health resources study, and you were talking about the Navigate project. Can you explore that project, what it is? And
it's a pretty impressive project that comes out of Sunnybrook Hospital in Toronto. And what they do is they have some people at the other end of the phone who help find shorter wait lists when there's a service, a mental health service that is private. They help negotiate lower rates. They help ensure that the referral is appropriate, that it's going to the right place. I've had patients referred to me that have waited months, and it was clear that they should have been referred for a different type of specialty. I've had kids that have been referred to me that really ought to have been managed perhaps by a generalist, more of a generalist. And with the resources provided by these navigation projects, sometimes these can be circumvented. So it's exactly what I think was talked about earlier in terms of not throwing money at things and making things more efficient. Having said that, there's still a big human resource gap, and there's a big two-tiered system with regard to mental health delivery that needs to be addressed. And so some funding, I think, is going to need to be applied.
Thank you, Dr. Feldman. Next, we're going to go back to the Conservatives. I'd like to welcome Mr. McGuire to the committee and invite him to take the floor for the next 5 minutes.
Thank you, Mr. Chair, and thank you to the witnesses as well. I wasn't here for the first part of this, but it's been very interesting to hear your comments and the questions from my colleagues on all parties here on these issues. But Mr. Feldman, I was most interested in, I think it was you that was mentioning about maybe all witnesses, about the priorities of youth and online training that Ms. Sadhu was just asking about as well. The amount of time there, the ease of being able to do that online is one thing for remote and other areas that Ms. Roy mentioned, I believe. But is there specific age groups when we're talking about youth that are more, can be more helped in that area than not? Giving the example that you used, Mr. Feldman and Dr. Feldman, about autism was the one that you used, I believe, and perhaps being able to expand on that.
Yeah, it's a wonderful resource to have this technology now to save time, money, visits, etc. But it has its limitations. So you'd think that the sort of patients that I see with mental health would be ideally suited for distance learning because you don't have to examine their abdomen or listen to their chest. But it turns out that you need to interact with them in person frequently to get a sense of their mood, to truly get a sense of their mood, their level of anxiety, their ability to pay attention, their social interactions, sometimes just to connect at a greater level, which is so important when establishing relationships with your patients. So I think that there is going to continue to be a need for both. And what I've started doing is seeing my patients, some of them, every second visit is delivered virtually. There are things, particularly for those kids who are on medications, they need to have their blood pressure checked and their height checked and their weight checked on accurate scales. And so that there's a need for both, but there is the great potential to reduce time and costs for both families and the system.
And Ms. Roy, do you have any comment, Doctor?
En fait, au-delà du fait qu'on a besoin.
Beyond the fact that we need to perceive and interact with the child, even though the diagnosis is easy to determine by screen, for the acceptability or the human side, when you have to intervene with the parents and explain a diagnosis that has many consequences, you mustn't lose the human side of medicine. That's my concern in all this. Moreover, when it comes to the intensity of follow-up, yes, we need to measure and weigh children often. Sometimes there have to be appointments between all that. perhaps for some follow-up it's okay, but for contact and for giving them a heavy diagnosis, even though it might be easy to do virtually, we must never lose sight of the fact that proximity and human contact and involving parents is very important in person.
As well, it may be actually easier to do those diagnoses for seniors, except they aren't the ones that are online as much in those areas. There's a priority here. I was just at a Hospital Foundation dinner on Saturday night in my own constituency, so this is very pertinent for me to be able to ask the questions here. I come from a largely rural area, and people have to travel distances, sometimes a couple hours to get to a major facility, major hospital. There's rural hospitals, and I'm wondering what your experience is with being doctors. The term nurse practitioners came up, and my experience in the Manitoba legislature was dealing with nurse practitioners, trying to promote them, doing quite a bit of the work that doctors do today. Is there a greater need for people like nurse practitioners in some of those rural areas versus our major hospitals to be able to alleviate the shortage of physicians we have, which is directly proportional to the needs and care of youth? Can you just comment on the how like there's regulations and things that we've talked about for online? Yes, it's nice to be able to do that, but what type of is there anything that a nurse practitioner couldn't do for these youth developments that can be the doctors are presently doing in those areas, and how would nurse practitioners be able to help alleviate the shortages we have across the country today?
Réponse bref, si vous pouvez.
Brief answer, if possible. Yes, a very brief. We have to take down the silos in medicine. Often we offer services by pharmacists, for instance, but yes, nurse practitioners already work in cooperation with us in Quebec. What we want is to have the child see a health professional quickly and effectively, and nurse practitioners will clearly help us with that. Thank you, Dr. Roy.
The last round of questioning today will come from Mr. Van Couverton for the next 5 minutes.
Thank you very much, Mr. Chair. I appreciate the opportunity to ask a follow-up. My preamble, unfortunately, took a long time in the previous round. So, Dr. Feldman, I'd like to go to you and just focusing in on a little bit of the preventative measures that I think are necessary and prudent. I think any further expenditure in terms of transfers, it would be prudent to meet those with efforts to ensure resiliency in child populations. I'm personally very focused on physical activity and sport in my work, but there are many, many other ways to ensure that kids develop that resiliency. Any comments from you on how we can ensure that fewer kids need to access mental health supports in the future?
So great question. I'd love to see universal daycare. I think that's going to be a wonderful thing. Exercise is key. So in the patients that I see, I'm heavily involved in managing kids with school and learning and development, attention problems. Exercise has been shown with good evidence, I can confidently say, has a demonstrable benefit in terms of attention span and reduction in anxiety. So promoting exercise, and a recent study showed just 20 minutes a day of aerobic exercise for kids can have a significant benefits. So that's huge. Many of these kids we may be able to prevent some of the mental health challenges. Nature and nurture are both important, though. And there are some kids that are born with the propensity for mental health issues that may not be preventable, but can be treated. And so both are going to be important, prevention and treatment.
Thank you very much. And just very briefly, not considering those two things, prevention and treatment, in two silos necessarily, but certainly like exercise and exposure to arts and programming and lots of other social interventions, if you'd call them, for people living with mental health challenges and illnesses. Has there been proven, not talking about prevention so much, but management? Is that also a preventative measure that could kind of I hate to use such a crude term, but like sort of slow down the tap a little bit on the number of people experiencing so many challenges or the severity of those challenges?
I think that there's so many different things that we can do that Dr. Waugh talked about, in particular, looking at exposure to social media. The Canadian Pediatric Society has a statement that we can provide that makes recommendations, best opinion recommendations, because it's an area that needs to be researched about what the limitations and how we should participate with our children's online experiences to keep them safe. But cutting down on spent time in the virtual world, getting out, doing more exercise, getting involved when possible in team activities, extracurriculars, making kids social again. We are social animals.
Dr. Waugh, je vois vous.
Dr. Waugh, I see that you're agreeing. Yes, I just wanted to say that that's the best way to finish this. I completely agree.
I see.
Thank you.
Time to the chair then in that case.
Thank you very much, Mr. Van Koeverden. That concludes rounds of questions, pretty much right at the top of the hour. Please stand by, colleagues. I'm just going to bid a goodbye to our witnesses. I have one small item of committee business to deal with. So to all of our witnesses, thank you so much for being with us today. We were fortunate to have one witness cancel, which allowed us to really get into the issues at some depth. And we very much appreciate the patient and professional way that you've handled all of the questions and the thoughtful presentations. It will be of great value to us as we proceed along this route of the Children's Health Study, which is a very, very broad range. We know that you're extremely busy and very much appreciate how generous you've been with your time today. So thank you, one and all. Colleagues, I have one quick housekeeping matter to raise with you. When we embarked upon this study, we did not set a deadline for the receipt of briefs. And if it's the will of the committee to establish a date, I would suggest perhaps a month from today, which would give people lots of time. And it's also unlikely that we will be completely done of hearing all of the witnesses by then. But the floor is open.
Mr. Chair.
Mr. Barrett?
Yeah, just based on the trajectory of the committee's work and the expectation that we do have some legislation coming our way, if you haven't had the opportunity already, could we just check with the analysts if that's going to provide us sufficient time, even though we'd still be receiving briefs in advance of our conclusion of the of hearing witnesses?
Sure, happy to chat with the analysts. It wouldn't be unusual for the deadline for briefs to happen before all the viva voce evidence, but I throw it open to the analysts, and I see Mr. Davies in the room as well, so perhaps we can hear from the analysts and then Mr. Davies.
And I concur, Chair. I'm just wondering if the date should in fact be earlier than 4 weeks. That's my question.
Understood.
I think, pardon me, we are happy with the month deadline. I think it'll still give us time to review those briefs and include them in the report if it's the committee's will with that deadline set.
Okay. Mr. Davies?
I'm in favor of the month.
Any further discussion? Do we have consensus to set the deadline for the receipt of briefs for this study for October 27th?
Yes.
Is there consensus in the room? The motion is adopted. Is there any further business to come before the meeting? Is it the will of the committee to adjourn?
It is.
We have consensus. We're adjourned. Thank you.